I'm Jeremy Abramson. I'm an associate professor of medicine at Harvard Medical School, and I direct the lymphoma program at the Massachusetts General Hospital Cancer Center in Boston. Dose-adjusted EPOCH-R is a regimen developed at the National Cancer Institute in the US with the goal of improving outcomes in rapidly proliferating tumors and to decrease the resistance related to multi-drug resistance protein expression. Dose-adjusted EPOCH-R is similar to R-CHOP in terms of the drugs that are used, but differs in a number of important ways. One is the addition of the drug etoposide. So our EPOCH-R includes all the drugs of R-CHOP plus the addition of etoposide. It also differs in how several of the drugs are administered. Etoposide, doxorubicin, and vincristine are mixed together and administered by a 96-hour continuous infusion rather than given as bolus dosing as the doxorubicin and vincristine are given in the R-CHOP regimen. The dose of prednisone is also different in that it's twice the dose that we give with R-CHOP. And in dose-adjusted EPOCH-R, we give 60 milligram per meter squared twice daily, as opposed to a once daily dose of prednisone in R-CHOP. And then finally, the regimen has the term dose-adjusted in the name, dose-adjusted EPOCH-R. And what dose-adjusted EPOCH-R means is that the doses of cyclophosphamide, doxorubicin, and etoposide are modified based on the nadir, neutrophil, and platelet counts in the prior cycle. In order to do this, the patient's CBC with differential is checked twice weekly throughout the course of therapy. And if they never reach a neutrophil count of less than 500 or a platelet count of less than 25,000, then the doses of the cyclophosphamide, doxorubicin, and etoposide are all increased by 20% with a subsequent cycle. If they again don't reach those thresholds, then they're increased another 20% with a following cycle. If the neutrophil count reaches 500 but remains there on one or two checks and then recovers, then the dose level is maintained the same. And if that neutropenia lasts for longer than a week, meaning 3 consecutive checks, or if the platelet count reaches 25,000 or lower, then the dose level is decreased by 20%. And so we use this to modulate each cycle. And the goal is to maximize the amount of chemotherapy that patients are given based on their hematologic tolerance. Now, where we use EPOCH-R has also evolved a bit over time. A recent randomized trial of R-CHOP versus dose-adjusted EPOCH-R in patients with diffuse large B-cell lymphoma conducted by the US Alliance Cooperative Group showed no benefit whatsoever for dose-adjusted EPOCH-R over R-CHOP in this common indication. So I would say that dose-adjusted EPOCH-R should not be used as standard treatment for diffuse large B-cell lymphoma. There are, however, some subsets where we have some suggestion of benefit based on small or retrospective studies. These include high-grade B-cell lymphomas with double and triple hit cytogenetics. These so-called double hit lymphomas appear to have inferior outcomes with R-CHOP, but better outcomes when treated with more intensive regimens like dose-adjusted EPOCH-R. And my standard approach in my practice for most patients with double hit lymphoma is to treat these patients with dose-adjusted EPOCH-R as opposed to R-CHOP. There's also the entity now of high-grade B-cell lymphoma not otherwise specified, which means they look more aggressive under the microscope than a standard diffuse large B-cell lymphoma, but doesn't have the cytogenetic definition of double hit lymphoma. In the absence of knowing how to treat these patients with high-grade B-cell lymphoma NOS, I also err on the side of treating these patients with dose-adjusted EPOCH-R. Notably, those patients were previously considered a so-called Burkitt-like lymphoma in older classifications. And indeed, Burkitt lymphoma is one of the B-cell lymphomas that we do treat as well with dose-adjusted EPOCH-R. Dose-adjusted EPOCH-R has published phase 2 multi-center data in Burkitt lymphoma that show really excellent outcomes using dose-adjusted EPOCH-R for Burkitt lymphoma. So I think it is one of several acceptable regimens that can be used as standard treatments for Burkitt lymphoma. Another histology where I favor dose-adjusted EPOCH-R is primary mediastinal B-cell lymphoma. Primary mediastinal B-cell lymphoma was historically treated with R-CHOP, usually with radiation therapy, given that these patients typically present with limited stage and bulky disease. However, we published data that show that there's an unacceptably high early treatment failure rate with R-CHOP. This observation that we had, among others, led to the investigation of dosage-adjusted EPOCH-R in primary mediastinal B-cell lymphoma. And a phase 2 study conducted at the NCI showed that 6 cycles of dosage-adjusted EPOCH-R produced really spectacular outcomes in patients with primary mediastinal B-cell lymphoma, with the vast majority of patients achieving a durable complete remission, and that this could be accomplished without the use of consolidated radiation therapy in nearly all patients. And then beyond those more common histologies, we also use dosage-adjusted EPOCH-R oftentimes in patients with AIDS-associated diffuse large B-cell lymphoma, which interestingly is one of the regimens where dosage-adjusted EPOCH was developed in order to treat HIV-associated large cell lymphoma. A retrospective analysis of patients treated in prospective studies by the AIDS Malignancy Consortium suggested a better outcome for patients treated in those trials if they received dosage-adjusted EPOCH-R rather than R-CHOP. I wouldn't say that this is a definitive recommendation, and there are certainly patients, especially in the modern era, with well-controlled HIV who present with DLBCL akin to a lower risk presentation as we might see in anybody without HIV. And those patients can probably be treated just as effectively with R-CHOP. But I always do consider dosage-adjusted EPOCH-R in AIDS-associated diffuse large B-cell lymphoma, particularly those presenting with high-risk advanced stage presentations. Then finally, there are some rare histologies where we have limited data for any regimen, but where historically we have favored more aggressive regimens like EPOCH-R. That includes plasmablastic lymphoma, as well as grade 3 lymphomatoid granulomatosis. So while the majority of patients with diffuse large B-cell lymphoma should receive R-CHOP, there are these selected subgroups that I do favor dosage-adjusted EPOCH-R at the present time.